Hi, today I'm going to simplify what is leukemia and lymphoma. Actually, leukemia and lymphoma both represents tumors of WBC. Both affects white blood cells. Okay, leukemia is specifically towards peripheral blood and bone marrow, while lymphoma is towards lymph node and organs. Okay, that's all. Firstly, we need to see what is lymphoma. Who classification of lymphoma? Okay, they classify lymphoma into Hodgkin's lymphoma and non-Hodgkin's lymphoma. While Hodgkin's lymphoma is less aggressive, non-Hodgkin lymphoma is more aggressive. And most common type is what? Yeah, non-Hodgkin's lymphoma is more common. Okay, in Hodgkin's lymphoma, lymph nodes present involvement is more, and the lymph node involvement will be in a contiguous manner. Okay, while it spreads from cervical, axillary, mediastinum, and abdomen, they are in a continuous pattern. But in non-Hodgkin's lymphoma, Valder ring involvement and peritoneal lymph node involvement will be more. First, we will see about what is Hodgkin's lymphoma. When Epstein-Barr virus attaches and attacks the B cell through the CD21 marker, it transforms the B cells into the Reed-Sternberg cells. What is the most characteristic of Reed-Sternberg cell? Owli. Yeah, the Reed-Sternberg cell is the characteristic of the Hodgkin's lymphoma. Okay, that's all. Hodgkin's lymphoma is classified into two based on the immunophenotyping. One is the classical and the other one is a nodularly predominant Hodgkin lymphoma. In classical, CD15 positive and CD30 positive, while NLPHL is what? BCL6 positive and CD20 and CD45 positive. In NLPHL, the main cell characteristic is a what? Popcorn Reed Sternberg cell. That's all. Acute leukemia. How can we diagnose acute leukemia? Through the bone marrow biopsy, and the blast count will be more than 20%. What are blast cells? Blast cells are nothing but the immature cells. Acute leukemia is divided into two according to the what cells are involved. One is a lymphoblast, which is that it will classified as acute lymphoblastic leukemia, and which is a myeloblast. Another one is a myeloblast, which is a acute myeloblastic leukemia. Okay, in exam, if they give a slide and ask you to answer which it is a what, ALL or AML, you need to look at the nucleus. If the cytoplasmic granules and nucleoli are absent, then it is a ALL. If the both are present, then it is a AML. Okay, acute lymphoid leukemia is further divided into B cell acute lymphoid leukemia and T cell acute lymphoid leukemia. In B cell acute lymphoid leukemia, it is mostly affects pediatric patients from 2 to 5 years of age. It may present as a anemia. Like its presentation is somewhat similar to the anemia. Okay, immunophenotyping of this one is CD10 positive, CD19 to 24 positive, CALLA positive, and PAX5 gene positive. The other one is the T cell ALL. It mostly prevalent among 13 to 17 years of age. The most important thing is it is a mediastinal mass presentation. Mediastinal mass presentation is a characteristic of the TALL. The immunophenotyping is nothing but the CD1 to 8 positive, CD28 positive, and Notch positive. Okay. Among these two ALL, BALL is prognosis is somewhat better than the TALL. Okay, then. Now we will see about the MDS. MDS is nothing but the myelodysplastic syndrome, which is a myeloid stem cell maturation defect. Okay, we can identify this by looking at the three signs, important signs. Okay, first one will be the ringed sideroblast, and second one will be the pseudopuger-Hewitt anomaly, and third one will be the Pohnball megakaryocyte. Next, we will see about the AML, which is a acute myeloid leukemia. Okay, myeloid MPO or myeloid peroxidase positive is an indicator for a AML. AML is generally classified from M0 to M7. Okay, we will see specifically about AML M3. Okay. Now we will see about the AML M3. AML M3 is most important for in exams perspective, because my FMG question paper contains this AML M3 question only. Okay, let's see which cell is the most characteristic for the AML M3 is a faggot cell, because faggot cell has a R rods, and the immunophenotyping will be the T15:17. Okay, because why this AML M3 is important? Because the treatment, what is the treatment for the AML M3 is a all trans retinoic acid, ATRA, which has a good prognosis. Okay, and the other important thing is the DIC is most commonly associated with this AML M3, and DIC can lead to coagulative consumptive coagulopathy. Okay, consumptive coagulopathy. Wow, if you ever encounter a question involving the AML and it has a history of bleeding or something, you just go for AML M3. Okay. Lastly, we will see about the CLL and CML. Both will what's the population it will present is the old age people above 60 years. Okay, and both have massive spleen. Okay, and the important thing is the CLL have a presentation of the smudge cells. Okay, and the lymph node is involvement of the lymph node will be high, while in the CML the lymph node peripheral lymph node involvement will be absent. Okay, and in the CML more immature cells will be present, like promyelocytes, myelocytes, and metamyelocytes, and the band forms are present more in the CML. Okay, in this chapter another more topics like Burkitt's lymphoma, multiple myeloma, and Langer cell histiosis. If I involve those two, it will take a long video. So if you want comment, I will definitely simplify that topics too. I think it will this video will give you a insight or basic foundation for approaching this approaching the leukemia and lymphoma for you, I guess. Okay, just stick to the basics. I think you can refer this as a basic model while studying from other resources, other professors. While studying from the professors, they will add some more points. You can just put it. This is a basic or foundation model. Okay, it will help. I think so. This is yeah, attempt from my side, trying to jump from my comfortable side to really uncomfortable side. So let's see. If you have any doubts, just feel free to comment. Okay, thank you. Subscribe, follow and subscribe. I think, yeah, that too. Thank you.